Chapter 19, Concepts of Cancer Development. The priority concept of this chapter is cellular regulation. The interrelated concept in the chapter is going to be immunity. All different types of cells work together in a predictable manner to make the whole body function at an optimal level. First, we're going to talk about normal cells. Each cell has a specific morphology. This means that you can tell them apart. They each have a distinct and recognizable appearance, including their size and shape. This is important to note because if you take a cell and put it underneath a microscope, a bone cell is going to look different than one from the intestinal tract. Cells like your hair cells, bone marrow, skin, and your intestinal tract, those all continue to grow throughout your lifespan. Because they are all different, each cell also has a specific and differentiated function that it performs within the body to carry out its normal functions. An example of this would be the cells in the heart. You can see that they have a different size, shape, and function than the cells in the intestinal tract. Nuclear to cytoplasmic ratio refers to the size of the nucleus as compared to the overall size of the cell. Adherence refers to how tightly cells are bound together. Most cells produce protein called fibronectin. Those are the proteins that create binds. The exceptions to these are going to be your WBCs and your RBCs. And that's for obvious reasons because we don't want them going around in the circulation and sticking to each other and forming clots. Non-migratory, that just means that normal cells don't go wandering around the body. The exception to this is going to be, of course, like your blood cells. Cellular regulation, that is referring to the division of cells. So normally it's all orderly and well regulated, and that they undergo a normal process of mitosis or division. And that happens for two reasons: to develop normal tissue and to replace lost or damaged cells. Contact inhibition refers to cellular regulation. This stops the division of cells when a dividing cell is completely surrounded and contacted by other cells. Cells can only divide when at least a small portion of their surface is not touching another cell. If you're a gardener, you can see a good example of contact inhibition when you're growing something in a pot, in a container, and you go to remove it to move it to a bigger pot. You can see that the roots don't extend outside the walls of that container. They might leave out of the bottom if you have drainage holes, but everything else is preventing that from growing. So it's being inhibited by contact. Apoptosis, this refers to programmed cell death. This can be pre-designed in normal cells or caused by other agents. I think of it this way, apoptosis, I think of a popping noise. The cell is popping. That's not really what's happening, but it just kind of triggers me to remember it. So you have apoptosis where the cell is dying. And then euploidy, that refers to having a complete set of chromosomes. So there's a couple different types of common alterations in cellular growth. One of them is referred to as benign. Typically they're harmless. They don't always require intervention, and it's normal cells growing in the wrong place or the wrong time. There are examples of benign cells that do need removal from the body. Sometimes people have benign tumors in the brain. And you think about it this way, there's only so much space in your skull. So a lot of times those benign tumors still need to be removed, even if they're not cancerous. Then we have malignant, which indicates cancer. So these are your abnormal cells, and they have a tendency to invade surrounding tissue. Cells are exposed to a variety of factors that can alter how the cell grows and how it functions. When cells alter in one way or another, they're considered abnormal. Benign tumor cells, those are the normal cells growing in the wrong place at the wrong time, but they do not invade surrounding tissue. They may cause other complications by pressing on healthy tissue or cutting off circulation, cutting off nerve impulses if it's in the spinal column, but they themselves are not cancerous. Benign tumors are a result of a small problem with cellular regulation. Some examples of them are moles, uterine fibroids, tumors, um, skin tags, endometriosis, nasal polyps. There's a lot of different examples of benign tumors out there. Some features of benign tumors, they have a specific morphology that is maintained, so they stay the same as the cells from which they arose. So if you have a tumor, let's say in a certain area, and you biopsy it and it's benign, it's going to look exactly like the original cells. So let's say it's a breast tumor, it's a fibroid or uterine fibroid, it's going to look exactly like that uterine tissue. They also maintain a small nuclear to cytoplasmic ratio, so they're not an alteration of size from the original cell. And their specific differentiation function is preserved. So endometriosis, as an example, is going to be the endometrial tissue that grows outside the uterus. Benign tumors also continue to produce fibronectin, and that keeps them tightly adhered to each other. There's no migration or wandering. They don't invade other tissues. It's not going to have metastasis like you see in cancerous tumors. They show an orderly growth pattern. They just overgrow. They're not needed. They just grow in the wrong place at the normal rate, and this indicates a problem with cellular regulation. And they also have normal chromosomes, so they're not altered in that capacity either. Okay, so 7 warning signs of cancer. We have caution. So that's going to be your changes in your bowel or bladder habits. And this is going to be a change from whatever your patient's baseline is. And keep in mind that everybody's a little bit different. It's not necessarily normal for every person in the world to have a bowel movement every day. It could be, one every other day or one every 3 days. So the key is here is going to be a change in what their normal baseline is. A sore that doesn't heal. So when I think of this, a lot of times I think of like actinic keratosis, which is a type of precancerous lesion on the skin, and they do not heal. They have to be removed. Unusual bleeding or discharge. A good example of this is going to be from like talking about the bowel again, if they're having rectal bleeding, or you have a patient that is bleeding, having unusual periods. Doesn't necessarily mean that they're having a menstrual cycle. Sometimes they're older and postmenopausal and they start bleeding again, and it's not necessarily a period. It could be something different, so they need to get that checked out. T, a thickening or a lump in the breast or anywhere. So if it's not normally there, you need to get it checked out. And it doesn't matter where it is. If something is thickened or a lump or they're palpating something unusual, it's time to get that checked. Indigestion or difficulty swallowing. Now, this doesn't mean that indigestion always is a problem. If your patient has GERD, that's their baseline, that's one thing. But the whole point of that is if it's a new finding, they need to get that investigated. And of course, difficulty swallowing. Obvious change in a wart or a mole. So if it suddenly looks different, it's irregular, it's dark on one side, it has some changes in color, consistency, whatever it is, it needs to get checked out. And then a nagging cough or hoarseness. And this kind of goes along with the difficulty swallowing. So cancer, malignant cells, we have abnormal cells that have a tendency to spread, they metastasize, and they invade and harm surrounding tissue, and they serve no useful function. Malignant tumors can arise from epithelial cells of the skin, the liver, the lungs, the stomach, the kidneys, the prostate, the thyroid. These tumors are called carcinomas. Anaplasia refers to the loss of specific morphology. As they become malignant, they begin to become smaller and rounder. Hence, many malignant cells tend to look very similar. They have a much larger nuclear to cytoplasmic ratio because a cancer cell's nucleus is larger than a regular cell nucleus, and the cancer cell itself is smaller than a normal cell. So you've got a large nucleus and a small cell. Their specific functions are also lost. That means they serve no purpose. So if you have a uterine tumor, it no longer carries out the function that a normal uterine cell would carry out. These cells also do not produce fibronectin. Therefore, they are loosely adhered. They break off as easily from the primary tumor, the original tumor, and that's a lot of times how we end up with metastasis. So no fibronectin. So migration, metastasis, again, that's because of the fibronectin. Because the cancer cells do not bind tightly, they have a tendency to migrate. In fact, they're covered with enzymes that allow them to slip right through blood vessel walls and tissues. And that's what leads to metastasis, and that's spreading of the tumor to surrounding tissues. And there's more than one way for metastasis to happen, but that's just one of the more common ways for it to happen. So with contact inhibition, that does not exist with cancer cells. They replicate even when all sides are surrounded and they're in contact with other cells. They are persistent. They don't have an off button, and it makes them difficult to control. So if you think about the example that I gave with the plant and the pot, we now have a plant that has broken the pot because it hasn't listened. It doesn't have that contact inhibition. Chromosomal abnormalities, they are present in cancer cells. And there's really no rhyme or reason to this. They could have too many chromosomes, they could have too few. Some that are there could even be broken or damaged. So the key here is that they're going to have chromosomal abnormalities. Carcinogenesis or oncogenesis, that refers to cancer development or the production of cancer cells. And malignant transformation refers to the process in which regular cells are changed into cancer cells. This occurs through the loss of cellular regulation, so cells become damaged and divide rapidly in an unorderly fashion. The first step in this, of course, is going to be the initiation. Initiation, that is your irreversible event, and this can lead to cancer development. This happens due to a persistence of carcinogens. Example of that is going to be like smoking, the cancer-causing agents, chemical agents, whatever it is. Barrett's epithelium is going to be another example in the esophagus, or viruses such as HPV. Promotion, that refers to enhanced growth of the cell by substances known as promoters. And these are going to be like your hormones, like your estrogens, your body proteins such as insulin, and they're going to cause malignant cells to divide more rapidly to become a tumor. The period between initiation and growth into the tumor is called the latency period, and that can range from months to years. Progression is the continued change of cancer, making it more malignant. After a tumor grows to about 1 centimeter, it has at least 1 billion cells. Once it begins to build its own blood supply, it becomes a health problem. As tumors grow, they contain less and less normal cells. And then, of course, metastasis we covered, that is going to be the spreading. The primary tumor is your original tumor and is identified by the tissue from which it arose. It is also called the parent tissue. So if you took this tumor and you biopsied it and you looked at it underneath the microscope, the tissue is going to look very similar to the original tissue from where it originated. So for example, if it is a tumor from the breast, the tissue in the tumor itself is going to look very similar to breast tissue. The secondary tumor, that's going to be your metastasis. And even though this tumor may have spread to other places, it remains the same type of tumor. So going back to what we were discussing with the breast cancer, if you had metastasis to another site like the lung, and you took a biopsy of that tumor from the lung, it would look similar to the tumor that was originally in the breast. And you'll see this sometimes with patients that have multiple tumor sites where they're biopsying it. And a lot of times what they're trying to determine is where the original site was. What was the original site for the cancer? The most common way for tumors to spread and metastasize is through blood-borne metastasis. Tumor cells are released into the blood and they're carried to different locations. Tumors can also spread via the lymph system in areas that are rich in lymph, like example again, like with breast tissue, a lot of times they're going to biopsy the lymph nodes that are located in the axillary area. And here are going to be the steps of metastasis that we discussed. So we have our malignant transformation. We have some cells that are becoming malignant. Then we have the tumor vascularization. So we've got a tumor with a rich blood supply. Blood vessel penetration, you see the cells here moving into the vascular space. And then they're traveling to invade other tissues. Cancers are classified by the type of tissue in which they originate. So you can have glandular or connective tissue, and those are going to be classified as either solid or hematologic. Solid tumors are going to be like your lung cancers or your breast cancers, and hematologic tumors are going to be like your leukemias and your lymphomas. Grading is going to be classifying cellular aspects of a tumor. Ploidy classifies the number and structures of chromosomes, such as normal or abnormal. Staging classifies the clinical aspects of the tumor, and it specifies the level of malignancy. High-grade tumors contain poorly differentiated cells which divide rapidly. These are aggressive tumors that spread. Low-grade tumors more closely resemble the cells from the tissue in which they originate. These tumors grow slower and they are less aggressive. The staging we'll go over more on the next slide, but the T refers to the tumor, the N refers to the number of lymph node involvement, and the M is the metastasis. Doubling time and meiotic index That is the growth index, which is the rate at which a tumor grows. For example, 10% would be the slow growing tumor, where 85% would be fast growing. This slide further breaks down the T and M. So with the T, when it's TX, we don't have a tumor, cannot be assessed. 0, no evidence of a primary tumor. Carcinoma in situ. And then we have staging T1, T2, T3, and T4. The increasing size corresponds with the increasing number. So T1 would be relatively small, and there are measurements associated with this. And then, of course, it gets larger as you go up. So T4 would be significantly larger than a T1. The other thing, too, is don't necessarily assume that because somebody has a large tumor that means they have metastasis or lymph node involvement. Lymph nodes, so we have in X, regional lymph nodes cannot be assessed. Sometimes there aren't any lymph nodes in that area that they would biopsy. In 0, that's going to be your ideal. There's no nodal involvement, so they removed a couple nodes and they were clear. In 1, in 2, in 3, increasing lymph node involvement in the regional nodes. And of course, again, the higher the number, the more nodal involvement. The M, metastasis. So ideally, we have none. Sometimes we can't determine this in certain types of cancer. So MX, present, cannot be assessed. M0, there's none. So they did a PET scan maybe, and they could not find any metastasis evident. And then, of course, some distance metastasis. So ideally, we don't want there to be any mets. There's also a pretty good table in your book that explains this as well. Always important to know risk factors, because risk factors are the driving force behind cancer etiology. And it's also important to educate your patients on reducing their risk factors. So we have chemical carcinogens. Chemicals equal drugs, like tobacco is a good example of that. And that accounts for about 30% of all cancers, especially lung cancer. Bladder cancer is another one. The leading cause of bladder cancer is smoking, is tobacco use. Alcohol could be another factor. Physical carcinogens can be like radiation, sun exposure, UV, chronic irritation. Viral, HPV is a good example of that. Epstein-Barr, hepatitis. We have vaccines now for HPV, so that it'll be interesting to see how the rates of that are affected over time. Dietary factors, animal fats, nitrates, red meat, low fiber, dyes. I could go on and on about that. So there's a lot of different things in our diets. And then, of course, personal factors like immune function, advanced age, and genetic risk. Cancer is not gender selective. It attacks both male and female. However, people with compromised immune systems are at a higher risk. A good example of that is when we get older, our immunity goes down. So adults older than 60 have a decreased immunity and therefore are at a higher risk. Patients who have had organ transplantation, so lung transplants, kidney transplants, those are going to be higher risk population because they take suppressive therapies. Also, HIV, they're at a higher risk for developing cancer. Advanced age. Age is going to be the single most important risk factor for cancer due to the fact that, like I just said, immunity decreases and the likelihood also of exposure to carcinogens over time. So somebody that's over 60 has had a lot more UV exposure than somebody that's 6 months old. Genetic risk. Many cancers are genetically linked. You've probably known families where there's multiple people in the family with cancer or rare forms of cancer. Breast cancer is one that has a strong genetic predisposition. There's many different types of other cancers I can give as an example, but think about families where there's a large population in that family unit that has similar or rare forms of cancers. If these types of genetic factors are present, genetic testing is always advised. We always want to focus on prevention. We don't want our clients to end up having an occurrence. So, primary prevention would be the avoidance of known carcinogens. So, we don't want our patients to smoke, as an example. Modifying associated risk factors, removal of at risk tissue. Again, I know I've been talking about breast cancer a lot, but this is one example where patients that test genetically positive for certain types of breast cancer may opt to have a prophylactic mastectomy to prevent them from ever developing cancer. Chemoprevention, that is drugs or other substances that target cancer cells and disrupt replication process. And vaccination would be like for HPV. Secondary is going to involve yearly screening. Fecal occult blood test or FOBT would be a good example of that. Annual mammograms for women over 40, colonoscopies, regular self breast exams. I believe the colonoscopy is after the age of 50 and then every 10 years after that. Digital rectal exam, that's actually falling out of favor a little bit. They don't do that as often as they used to. Now they just go right for the prostate antigens and they will test your blood. If a familial history of a certain type of disease is in order, a lot of times that pushes back the ages on some of the screening. So, for example, if you have a strong familial history of colon cancer, they're going to start screening you at a much younger age than 50 years old. So, don't assume that those ages are hard stops on that. If you're high risk, they're going to start screening you sooner. The other thing that will play a factor in there is if a patient has certain types of risk factors. One of that I can think of is Crohn's disease. So patients with Crohn's disease are at a higher risk for developing colon cancer. So they will routinely screen those patients. The rest of the PowerPoint is review questions, and I will go ahead and post that to Blackboard. This concludes the PowerPoint presentation for concepts of cancer development.